In the second part of local and humoral control of tissue blood flow, the student will be able to explain how the endothelial cells take part in control of tissue blood flow, explain how does phosphodiesterase 5 inhibitors help to treat erectile dysfunction, give an example to vasoconstrictor substances released from the endothelial cells, explain how tissue blood flow is regulated in the long term. The student will be able to describe the role of tissue vascularity in long-term regulation of blood flow, explain the role of oxygen in long-term regulation of tissue blood flow, describe the importance of oxygen partial pressure change in retrolental fibroplasia in the newborn babies, list the angiogenic peptides, list the anti-angiogenic substances, list the specific tissues where additional mechanisms take part in the regulation of blood flow, explain how collateral blood vessels develop when an artery is blocked, describe how blood vessels remodel in response to long-term changes in blood pressure and blood flow, list and explain the vascular remodeling types, list the hormones taking part in the regulation of tissue blood flow, list the effects of chemical factors on tissue blood flow, and explain why vasodilators or vasoconstrictors have little effect on long-term blood flow to a tissue. Now, endothelial cells control blood flow by releasing vasodilator nitric oxide. Local mechanisms for controlling tissue blood flow act mainly on the very small microvessels of the tissues, because local feedback by vasodilator substances or oxygen deficiency can reach only these vessels, not the larger arteries upstream. When blood flow through the microvascular portion of the circulation increases, however, the endothelial cells lining the larger vessels release a vasodilator substance called endothelium-derived relaxing factor, which appears to be mainly nitric oxide. This release of nitric oxide is caused in part by increased shear stress on the endothelial walls, which occurs as blood flows more rapidly through the larger vessels. The release of nitric oxide then relaxes the larger vessels, causing them to dilate. Without the dilation of larger vessels, the effectiveness of local blood flow would be compromised because a significant part of the resistance in blood flow is in the upstream arterioles and small arteries. So, in this figure, you see the endothelium. These are the endothelial cells, and this is the vascular smooth muscle, and this is the blood. Okay, when blood flows in the capillary or blood vessel, a shear stress occurs, and then it activates the ENOS, endothelial dependent nitric oxide synthase enzyme, causing the synthesis of nitric oxide, which activates soluble guanylate cyclase enzyme in the smooth muscles and converting cyclic GTP to cyclic GMP. Cyclic GMP causes relaxation of the smooth muscle. In this way, the diameter of the blood vessel will be increased, and then blood flow to the tissue will be increased. Okay? When blood flows through the arteries and arterioles, this causes shear stress on the endothelial cells because of viscous drag of the blood against the vascular walls. This stress contorts the endothelial cells in the direction of flow and causes significant increase in the release of nitric oxide. The nitric oxide then relaxes the blood vessels. This is fortunate because the local metabolic mechanisms for controlling tissue blood flow dilate mainly the very small arterioles and arterioles in each tissue. Yet, when blood flow through a microvascular portion of the circulation increases, this secondarily stimulates the release of nitric oxide from larger vessels due to increased flow and shear stress in these vessels. The released nitric oxide increases the diameters of the larger upstream blood vessels whenever microvascular blood flow increases downstream. Without such a response, the effectiveness of local blood flow control could be decreased because a significant part of the resistance to blood flow is in the upstream small arteries. Nitric oxide synthesis and release from endothelial cells are also stimulated by some vasoconstrictors, such as angiotensin II, which bind to specific receptors on the endothelial cells. The increased nitric oxide release protects against excessive vasoconstriction. When endothelial cells are damaged by chronic hypertension or atherosclerosis, impaired nitric oxide synthesis may contribute to excessive vasoconstriction and worsening of the hypertension and endothelial damage, which, if untreated, may eventually cause vascular injury and damage to vulnerable tissues such as heart, kidneys, and the brain. Even before nitric oxide was discovered, clinicians used nitroglycerin, amyl nitrates, and other nitrate derivatives to treat patients suffering from angina pectoris, severe chest pain caused by ischemia of the heart muscle. These drugs, when broken down chemically, release nitric oxide and evoke dilation of blood vessels throughout the body, including the coronary blood vessels. Other important applications of nitric oxide physiology and pharmacology are the development and clinical use of drugs, for example, sildenafil, that inhibit cyclic GMP-specific phosphodiesterase 5, an enzyme that degrades cyclic GMP. By preventing the degradation of cyclic GMP, the phosphodiesterase enzyme 5 inhibitors effectively prolong the actions of nitric oxide to cause vasodilation. The primary clinical use of the phosphodiesterase 5 inhibitors is to treat erectile dysfunction. Penile erection is caused by parasympathetic nerve impulses through the pelvic nerves to the penis, where the neurotransmitters acetylcholine and nitric oxide are released. By preventing the degradation of nitric oxide, the phosphodiesterase 5 inhibitors enhance the dilation of the blood vessels in the penis and aid in the erection. Endothelial cells also release vasoconstrictor substances. The most important of these substances is endothelin, a peptide that is released when blood vessels are injured. The usual stimulus for release is damage to the endothelium, such as that caused by crushing the tissues or injecting a traumatizing chemical into the blood vessel. After severe blood vessel damage, release of local endothelin and subsequent vasoconstriction help prevent extensive bleeding from arteries. Long-term blood flow regulation. Most of the mechanisms discussed thus far act within a few seconds to a few minutes after local tissue conditions have changed. Even with full function of these acute mechanisms, blood flow usually is adjusted only about three-fourths of the way back to the exact requirements of the tissues. Over a period of hours, days, and weeks, long-term local blood flow regulation develops that helps adjust the blood flow so it matches precisely the metabolic needs of the tissues. Changes in tissue vascularity contribute to long-term regulation of blood flow. If metabolism of a tissue is increased for prolonged periods, the physical size of the vessels in the tissue increases. Under some conditions, the number of blood vessels also increases. One of the major factors that stimulates this increased vascularity is low oxygen concentration in the tissues. Animals that live at high altitudes, for instance, have increased vascularity. Likewise, fertile chicks hatched at low oxygen levels have up to twice as much vascularity as normal fetal chicks. This growth of new vessels is called angiogenesis. Angiogenesis occurs mainly in response to the presence of angiogenic factors released from ischemic tissues, tissues that are growing rapidly, and tissues that have excessively high metabolic rates. Figure 17.6 shows the large increase in the number of capillaries in a red anterior tibialis muscle that was stimulated electrically to contract for short periods of time each day for 30 days, compared with the unstimulated muscle in the other leg of the animal. So here you see before stimulation there are few capillaries, and after 30 days stimulation, each day stimulated frequently, and you see the increase in capillary density in skeletal muscle, red anterior tibialis muscle. Okay. Role of oxygen in long-term regulation. Oxygen is important not only for acute control of local blood flow, but also for long-term control. One example of this is increased vascularity in tissues of animals that live at high altitudes where the atmospheric oxygen is low. A second example is that fertile chicks hatched in low oxygen have up to twice as much tissue blood vessel conductivity as is normally true. The same effect is also dramatically demonstrated in premature human babies put into oxygen tents for therapeutic purposes. The excess oxygen causes almost immediate cessation of new vascular growth in the retina of the premature baby's eyes and even causes degeneration of some of the small vessels that already have formed. Then, when the infant is taken out of the oxygen tent, there is explosive overgrowth of new vessels to make up for the sudden decrease in available oxygen. Indeed, there is often so much overgrowth that the retinal vessels grow out from the retina into the eye's vitreous humor and eventually cause blindness. This condition is called retrolental fibroplasia. Many angiogenic factors are small peptides. Four of the best characterized angiogenic factors are vascular endothelial growth factor, fibroblast growth factor, platelet-derived growth factor, and angiogenin, each of which has been isolated from tumors or other tissues that are rapidly growing or have an inadequate blood supply. Angiogenesis begins with new vessels sprouting from small venules or occasionally capillaries. The basement membrane of the endothelial cells is dissolved, followed by the rapid production of new endothelial cells that stream out of the vessel in extended cords directed toward the source of the angiogenic factor. The cells continue to divide and eventually fold over into a tube. The tube then connects with another tube budding from another donor vessel and forms a capillary loop through which blood begins to flow. If the flow is sufficient, smooth muscle cells eventually invade the wall, so that some of these vessels grow to be small arterioles and or perhaps even larger vessels. Certain other substances, such as some steroid hormones, have exactly the opposite effect on small blood vessels, occasionally even causing dissolution of vascular cells and disappearance of vessels. Therefore, blood vessels can also be made to disappear when not needed. Peptides produced in the tissues can also block the growth of new blood vessels. For example, angiostatin, a fragment of the protein plasminogen, is a naturally occurring inhibitor of angiogenesis. Endostatin is another anti-angiogenic peptide that is derived from the breakdown of collagen type 17. Although the precise physiological functions of these anti-angiogenic substances are still unknown, there is great interest in their potential use in arresting blood vessel growth in cancerous tumors and therefore preventing the large increases in blood flow needed to sustain the nutrient supply of rapidly growing tumors. Collateral blood vessels develop when an artery or a vein is blocked. New vascular channels usually develop around a blocked artery or vein and allow the affected tissue to be at least partially resupplied with blood. An important example is the development of collateral blood vessels after thrombosis of one of the coronary arteries. Many people older than 60 years have blockage of at least one of the smaller coronary arteries, yet most people do not know that it has happened because collateral blood vessels have gradually developed as the vessels have begun to close, thereby providing blood flow to the tissue sufficient to prevent myocardial damage. It is in instances in which thrombosis occurs too rapidly for the development of collateral blood vessels that serious heart attacks occur. Vascular remodeling in response to chronic changes in blood flow or blood pressure. The structure of large blood vessels also adapts to long-term changes in blood pressure and blood flow. In chronic hypertension, for example, the large and small arteries and arterioles remodel to accommodate the increased stress of higher blood pressure. In small blood vessels that constrict in response to increased blood pressure, the vascular smooth muscle cells and endothelial cells gradually, over a period of several days or weeks, rearrange themselves around a smaller lumen diameter. This process is called inward eutrophic remodeling and results in no change in the total cross-sectional area of the vascular wall. So on top you see inward eutrophic remodeling. What else you see? You see hypertrophic remodeling, outward remodeling, and together outward hypertrophic remodeling. In larger arteries that do not constrict in response to the increased pressure, the vessel wall is exposed to increased wall tension that stimulates a hypertrophic remodeling response and an increase in the cross-sectional area of the vascular wall. The hypertrophic response increases the size of the vascular smooth muscle cells and stimulates the formation of additional extracellular matrix that reinforces the strength of the vascular wall to withstand the higher pressures. Vascular remodeling also occurs when a blood vessel is exposed chronically to increased or decreased blood flow. After creation of a fistula connecting a large artery and a large vein, the blood flow rate increases in the artery due to a reduction in downstream muscular resistance and eventually leads to increased diameter of the artery, outward remodeling, while the thickness of the vessel may remain unchanged. However, wall thickness, lumen diameter, and cross-sectional area of the vascular wall on the venous side of the fistula increase in response to increases in pressure and blood flow. This is called outward hypertrophic remodeling. For example, in patients with renal failure who undergo dialysis, an arteriovenous fistula directly from the radial artery to the antecubital vein of the forearm is created to permit vascular access for dialysis. Blood flow rate in the radial artery may increase as much as 10 to 50 times of the normal flow rate depending on the patency of the fistula. As a result of high flow rate and high shear stress on the vessel wall, the luminal diameter of the radial artery increases progressively, meaning outward remodeling occurs, while the thickness of the vessel wall may remain unchanged, resulting in an increase in cross-sectional area of the vascular wall. In contrast, wall thickness, lumen diameter, and cross-sectional area of the vascular wall on the venous side of the fistula increase in response to increases in pressure and blood flow, meaning outward hypertrophic remodeling occurs. This pattern of remodeling is consistent with the idea that long-term increases in vascular wall tension cause hypertrophy and increased wall thickness in large blood vessels, while increased blood flow rate and shear stress causes outward remodeling and increased luminal diameter to accommodate the increased blood flow. These patterns of remodeling suggest that long-term increases in vascular wall tension cause hypertrophy and increased wall thickness in large blood vessels, while increased blood flow rate causes outward remodeling and increased luminal diameter in order to accommodate the increased blood flow. Chronic reductions in blood pressure and blood flow have the opposite effects. Thus, vascular remodeling is an important adaptive response of the blood vessels to tissue growth and development, as well as to physiological and pathological changes in blood pressure and tissue blood flow. Now, humoral control of the circulation. Several hormones are secreted into the circulation and transported into the blood throughout the entire body. Some of these hormones have important effects on circulatory function. Norepinephrine and epinephrine. They are released by the adrenal medulla, act as vasoconstrictors in many tissues by stimulating alpha-adrenergic receptors. However, epinephrine is much less potent as a vasoconstrictor and may even cause mild vasodilation through stimulation of beta-adrenergic receptors in some tissues, such as skeletal muscle. Angiotensin II. Angiotensin II is a powerful vasoconstrictor that is usually formed in response to volume depletion or decreased blood pressure. Vasopressin. Vasopressin, also called antidiuretic hormone, is one of the most powerful vasoconstrictors in the body. It is formed in the hypothalamus and transported to the posterior pituitary, where it is released in response to decreased blood volume, as occurs with hemorrhage, or increased plasma osmolarity, as occurs with dehydration. Prostaglandins. They are formed in almost every tissue in the body. These substances have important intracellular effects, but some of them are released in the circulation, especially prostacyclin and prostaglandins of the E series, which are vasodilators. Some prostaglandins, such as thromboxane A2 and prostaglandins of the F series, however, are vasoconstrictors. Bradykinin. Bradykinin, which is formed in the blood and in the tissue fluids, is a powerful vasodilator that also increases capillary permeability. For this reason, increased levels of bradykinin may cause marked edema and increased blood flow in some tissues. Histamine, a powerful vasodilator is released into the tissues when they become damaged or inflamed. Most of the histamine is released from the mast cells in damaged tissues or from basophils in the blood. Histamine, like bradykinin, increases capillary permeability and causes tissue edema, as well as greater blood flow. The local vasodilatory and edema-producing effects of histamine are especially prominent during allergic reactions. Ions and other chemical factors can also alter local blood flow. Many ions and chemical factors can either dilate or constrict local blood vessels. Their specific effects are as follows. Increased calcium ion concentration causes vasoconstriction. Increased potassium ion concentration causes vasodilation. Increased magnesium ion concentration also causes vasodilation, like sodium ion. Increased sodium ion concentration causes vasodilation. Increased osmolarity of the blood caused by increased quantities of glucose or other non-vasoactive substances causes vasodilation. Increased hydrogen ion concentration causes vasodilation. Increased carbon dioxide concentration causes vasodilation in most tissues and especially marked vasodilation in the brain. Most vasodilators or vasoconstrictors have little effect on the long-term blood flow unless they alter metabolic rate of the tissues. In most tissues, tissue blood flow and cardiac output, the sum of flow to all of the body's tissues, are not substantially altered, except for a day or two in experimental studies when one chronically infuses large amounts of powerful vasoconstrictors such as angiotensin II or vasodilators such as bradykinin. Why is blood flow not significantly altered in most tissues, even in the presence of very large amounts of these vasoactive substances? To answer to this question, we must return to one of the fundamental principles of circulatory function that we previously discussed, the ability of each tissue to regulate its own blood flow according to the metabolic needs and other functions of the tissue. Administration of a powerful vasoconstrictor, such as angiotensin II, may cause transient decreases in tissue blood flow and cardiac output, but usually has little long-term effect if it does not alter metabolic rate of the tissues. Likewise, most vasodilators cause only short-term changes in the tissue blood flow and the cardiac output if they do not alter tissue metabolism. Therefore, blood flow is generally regulated according to the specific needs of the tissues as long as the arterial pressure is adequate to perfuse the tissues. So we have come to the end of the second part of the tissue blood flow regulation. Thank you very much for listening.